Okay, hopefully you're seeing the first slide here. Again, we're hoping to have a conversation with all of you today where we present our ideas and get some feedback from you. Again, we've been listening over the years. There's been a fair amount of feedback that we've solicited and that's been offered regarding the certification process. And we're trying to look for efficiencies for both SDS and you and the provider community. There's some challenges to that. You know, we've heard that the process for certification can be considered tedious and complicated. We're challenged at SDS to assure we're meeting the federal standards for qualified providers. We'll be talking more about that later, but our assurance to the federal government that we have qualified providers is rooted in the certification process. So there are two avenues we have to meet, both with the federal government and trying to work with you to assure that we are meeting those standards. And our unit resources devoted to this body of work have been maximized over the years as new services, new programs, new requirements, settings being one of those that we've all been through together. They have really maximized the unit, and we're looking for efficiencies in the certification process, and that's part of what we're going to be discussing today. We're going to consider some changes, discuss some ideas, and again, this is more for us to present some ideas, both that have come from the provider community and from within our own SDS units about the certification process. Looking forward to you, again, using the chat box. And then there'll be other avenues to provide your feedback through email. That's our goal today. Next slide. So the considerations, a few things we're going to talk about. We're going to talk about extending the period of time that a certification is awarded. We're going to talk about adding a probationary period or probationary status to the certification workflow, and talk about adding certification application fees. We also want to enter into discussion about some thoughts we have around national accreditation and honoring possibly those agencies who have sought that additional higher standard of accreditation. And then at the end, we'll have a conversation, as mentioned earlier, Lynn Kyleman-Cruz will join us and we'll talk about some quality performance measures and other things that impact provider reporting and our reporting to the federal government. So launching right into the considerations and discussions. Next slide. The variable certification process first. So what we want to do is or the goal here, obviously, as it says, is to maximize efficiencies for both providers and for SDS and my unit staff. We are a small but mighty staff. What we're looking at is changing from the standard 2-year certification cycle once a provider has met that first year status to a variable 1 to 4-year certification period. The 2-year period we find that to be, when we did some research across the country, that's one of the shorter certification cycles for this HCBS provider type. So we're looking to see if there's an opportunity to extend that based on certain criteria, which we'll talk about. But, you know, to allow for providers and for us to not have to review as often, but do more of a quality review at those interval periods. The interval periods, the certification periods, will be based on a result of a compliance review and service delivery monitoring and all the things that we do currently, but that will be the evaluation method for determining if a provider will get anywhere from a 1 to a 4-year certification period at renewal. Next slide. The second part to this variable certification period is an introduction of a possible probationary status. Currently, when providers are adding a new location or are a new provider, we do a 1-year initial certification period. So it kind of will look like that. It's an initial 1-year period, but we're expanding the thought to discuss with you about that being a probationary status. The goal would be to allow providers to demonstrate their Medicaid operations, and also to allow SDS to determine if there's needed additional technical assistance, if there's some short-term compliance challenges that may have arose during the first years of operations. And that would allow that focused attention from SDS during that period of time. As many folks may know, on occasion there are providers that face a variety of challenges that come up, and it's our goal and our hope to work with providers during that initial period of eligibility as a provider to make sure that we can set the provider on the right path forward, that early intervention model, as you might be familiar with in other lines of business, and then also encouraging the provider to be proactive in aligning and compliant processes. So again, that early intervention, seeing demonstration of Medicaid services, we'll be looking essentially for practices that are in alignment with the policies and procedures that a provider submits to us. We'll look for demonstration of that to be in operation in that probationary period. Next slide. So again, that's for new providers and new locations. What I also want to offer for feedback is the idea of currently certified providers who may be facing some compliance issues, possibly being placed in a probationary status as well. Again, for the same reasons, to have SDS have the opportunity to work with the provider to correct any operational findings, compliance findings, and have that focused attention with the provider's buy-in for that period of time. So again, the probationary period would be for new providers and new locations, and possibly for currently certified providers who may be in a 2, 3, or 4-year certification cycle that has an issue or issues arise where that we might benefit from a probationary period with some more oversight and involvement with that provider. Those of you who have residential settings may find this to be familiar. Our partners at Residential Licensing also have the same type of workflow and statuses through their licensing. They have a provisional license and an ongoing biannual license. So there is some similarities here, and they have a long history of this working well for them. So we have a strong partner that has a similar process. And again, those of you who have licensed settings would find this to be familiar. That is consideration 1, the sliding variable certification period with the introduction of a probationary status within that certification period. So we look forward to your thoughts. Offer your thoughts on that through the feedback loop as you think about how that impacts you as a provider. So next slide. The second consideration that we'd like to offer for input today is creating a provider certification fee structure. And the goal here is to engage a provider's comprehensive and active engagement in the provider application process. Again, you might find those folks who are those providers who have experience with residential licensing. There is a fee structure similar to their body of work that we're introducing here. Fees would apply to initial certification applications, timely renewal applications, late renewal applications, added services, added locations. And the reason we're looking for this is to encourage providers to accurately and completely supply SDS with the necessary application documents in a timely manner. We're looking at a fee schedule from $100 to $150, depending on the type of application it might be. You know, one of our challenges here we'd like to put out for you guys to maybe offer some thoughts on is we really struggle with late renewal applications. And the thought here would be that a late renewal application might have a higher fee. We're using a lot of resources that we have for many years, contacting providers to submit their applications timely, and often that's the last couple of weeks of the certification period. We're working really hard to make sure we at least get an application in so that we don't disrupt services and sometimes displace them from their homes. And so that is one of the reasons for the late renewal application fee. Regulatory requirements require that application to be turned in 60 days prior to its expiration date, and we have a high rate of late applications. And so we're looking for your help with that, and this is one of the methods we're considering, and look forward to your feedback. But again, initial applications and adding services, adding locations, a fee to encourage the provider to actively engage in the process, ensure we've got a complete application. We struggle with that. We're often having to return incomplete applications that are missing the minimum core requirements that we require. And we're using a fair amount of staff resources for that. So we're looking for your help in that, and I would encourage your comments about this consideration to help address this. And again, like I mentioned earlier, it's a lot like our licensing partners and the fee structure that they have. So provide your thoughts on that. It is something that we're considering, but we want to engage with you in that conversation and see what impacts we might not be thinking of and your thoughts on that. Next slide, thank you. And the other discussion we'd like to have is about, I mentioned it earlier in the introduction, is about a national accreditation. Some providers in Alaska have chosen to be nationally certified, or accredited is the term, by any of these agencies you see on the slide. And we have an idea to try to recognize providers who take this extra step. It's an extra step towards, you know, more involved oversight and just a service excellence kind of criteria we're looking for. We do acknowledge that this would be a significant challenge to SDS in developing this process to do a crosswalk of what a national accreditation might be as it relates to the certification process. For instance, what might a national accreditation and proof might relieve in the certification process. And we would need significant assistance from the provider community to develop this potential future practice. But it is a thought we've had under, you know, considering streamlining and opportunities for the certification process. So we would ask that you just offer some thoughts on that. If you're interested in a national accreditation substituting for part of the certification process, what that would look like, what documents that would look like for those of you who are nationally certified, or for those who might be interested in doing that. Again, this is more of a much more down the road kind of a discussion or an implementation if it were to be implemented at some point. There's a lot more work to be done with this. But it has been something we've been thinking about for a number of years. We've had providers come to us on occasion and mention this. So it's through your also, you know, interest that we bring this to you today to provide feedback on how this may work. We would rely on yourselves and the provider stakeholder groups to work with us to come up with a process if this is something we agree to move forward with. And next slide. And actually, I'm going to hand it over to Lynn Chief of Quality. She's got some items here to discuss with all of you. Thank you.
I'm muted, unmuting myself, saying good morning to all of you. Thank you for joining us today. And I just wanted to say good morning and welcome. I will stop sharing my webcam because I don't like my COVID look. But let's talk about quality. So one of the things I wanted to talk to you all about is the fact that we have our home and community-based waiver renewals coming due July 1st. And so for those of you that may know our process or may not know our process, I'm just going to give you a little bit of an overview. So the waivers we apply for with the federal government, with CMS, to be able to deliver home and community-based services through all of our waivers. And in order to do that, we have to fill out an application and describe most of our processes. And we have to make some assurances to the feds because they're giving us, you know, a large lion's share of money for being able to administer these programs. And we assure them through our quality assurance program, through our performance measures, of how we are meeting the mark. And so as Cherry pointed out earlier, with qualified providers, that is a part of one of our task committees in our quality improvement process. And it is one of the things that we have to assure that we're meeting the federal requirements for qualified providers. And so many of the things that we suggest to you or have to do in the certification process come directly from our assurances to the federal government that we're doing everything in our power to ensure that a provider is qualified and that they're going to protect the health and safety, health and welfare of all the people they serve. This is a long kind of process, and we have to write the waivers. We have to come up with all of the performance measures that are going to help us measure how we're doing. And then we always have to provide that evidence to CMS. So we provided evidence to CMS, I think, I don't know, maybe early in the year this year or late last fall. As part of their renewal packages for all states, they are sending a team. It used to be in person, but with COVID, they're not able to. So we're meeting regularly with some contractors and CMS to review all of our performance measures and make sure that we're on the mark for when we do renew. And so we have to respond to our evidence. They had some questions, and you know, that's normally my body of work. And then we also have to create performance measures for the next 5-year cycle of the waivers. And part of that is in developing performance measures is to make our performance measures as meaningful as possible. You know, that's always constantly the struggle, is how do you make something meaningful and useful without having it just be another piece of paper. And I'm sure you all can feel my pain in that. We also, you know, CMS is greatly focused on health and welfare. So they have revised a lot of their stuff since I've been in this position, probably in the last 10 years, and focus more and more on health and welfare. And part of that being said, when we look at our measures and we're going through it with the contractors, they recently brought up the fact that we only have 2 measures that measure training, that we assure that care coordinators are being trained in their certification period, and we assure them that the critical incident report training has been issued to all provider agencies. And, you know, we have the expectation that then all of you will train all of your employees. In our most recent discussion with them, we are kind of in negotiations back and forth on the fact that they don't think we have enough of those measures. They don't think we're measuring all of the training that you all do out in the world. And so we focus a lot on the policies and how you develop your training plan and we have a policy for training. You develop your restrictive intervention policy and you're expected to train to that. You develop your med administration training and you're expected to, or how you're going to deliver that training, and you're expected to train everyone. So what we're really struggling with now is, coming up with performance measures for additional trainings without making it onerous to you or to us. I mean, at this point in time, especially with COVID, we're definitely sensitive to everyone's resources, including our own. And so just wanted to throw that out there that, we're sort of in negotiations. We're going back and forth a little bit with CMS on this. And we had some thoughts, and I just wanted to throw it out to you guys to see if you had any thoughts about how we might do that in a way that could assure the feds that everyone is being trained. So some of the ideas that they had were that we need to do a sample and do an audit on all of our providers with training that are providing training, representative sample of each person coming due. We talked about adding an assurance to our certification packet that says you have conducted all the trainings, and I'm not sure if that would suffice with CMS. And we also talked about, perhaps giving you the quality improvement tool and adding some questions to that, where everyone would then give us back the quality improvement tool with those questions added, and then maybe we would sample from that. It's kind of complicated and very time intensive any way we look at it. We have made revisions to the CERT process in recent years. Cherry and her team really wanted to make it a little bit easier on all of you and easier on them. And so, we have, reduced the number of policies we require and focus really on health and welfare and assurances, added assurances to help us not have to review your policies. So those are my thoughts. And we have a quality improvement plan. So we've required that of all providers to submit that to us in their certification packet. We have mocked up a sample provider improvement, a quality improvement tool that we would put out to you and we would recommend at this point. And I know many people have some very complicated quality improvement reports, and they do a really good job on it, and others don't do a good job on it. I'll just be really frank. They barely respond to the questions, and we constantly are doing a back and forth. So we just thought if we added this recommended tool and put it out there for folks, it may be something that you could use, you could give us feedback on, and we are totally prepared to do that in the next few weeks here. And I just wanted to let you know that that's what we're sort of struggling with always, is how do we make meaningful performance measures that don't require a bunch more paperwork for you or us, that are meaningful, that we can actually tell that you're providing training and that we have a qualified provider at the end of the process. And that's really all I wanted to talk to you about, is let you know that we're going through that. And hope that we could get some feedback from you on any of these things. If anyone has any great ideas, or you think of ways that we could capture how you are providing training in a really succinct way without having to do an on-site or an audit, that would be great. I don't know how much of that will go with CMS, but that's what we're working on. And you can go to the next slide, Kara. So I think we're open for questions, feedback, and Kara, I would assume you'll take over from here, and I'll put myself back on mute.
Yes, thank you, Lynn, for all this great information, and thank you to our folks participating, because there's a lot of sharing of questions and feedback here. It may be that we might not be able to get to every one of these, and sometimes what we do is we take a look and see if a lot of people are kind of asking the same theme or have the same theme for feedback. So we'll just summarize it. So if you don't hear me read out your question, word for word, don't worry, it's there. It's in a report. Like I stated at the beginning, we put all this information together as we develop, develop the process towards regs. Again, this is just information sharing at this point, wanting to get your feedback, and thank you for your input here. There's a number of positive comments about taking into account providers that are accredited and because they have annual audits or periodic audits, and then the recertification to happen a few years out. There's a couple of comments about 5 years, thoughts that, it should be about 5 years if you have a good track record. So there's a few of us saying that. A few of us are asking about if we've discussed or understood the impacts the fees would have on smaller agencies. Any thoughts on that?
I think those are things that we've considered and would be interested in hearing more about. They are a nominal, and again, if we would extend certification for some providers for 2, 3, 4 years, it would be a fee every 3 or 4 years. And it's more in alignment. When we did the research across the country, and looking at these proposals today, more often than not, there was a fee, and more often than not, it was much higher than the fee that we are recommending.
Mm-hmm.
So just want to offer that. But yeah, we would take any of the questions, concerns, feedback on that providers would have, including smaller agencies.
Thank you, Cherry. There's a few questions here that are summarized by the question, would each licensed location require separate fees?
So if a location is individually certified, which most of them are, that's a requirement. If a new rendering location, it would require a fee because it would be a separate application for each location. In the beginning, we tried to make that clear. Maybe I can help make that more clear, that each location that's individually certified would be subject to the application and a possible fee.
Okay, thank you. A few of us have written in about the idea of considering a fee only if the application is late. So that's a thread here, more so just comments rather than questions. Some have asked about training and the current requirements for training. Would providers be required to pay for classes they take, or would the fee encompass all of the training that they would possibly take? I can start an answer maybe, or start info on that. SDS classes that we run through our training unit don't have a charge, so we don't charge tuition. Other trainings that we don't run, such as CPR, first aid, those trainings are separate individuals that do that. They're, approved trainers, so they charge fees for that. Other trainings that apply to our care coordinator continuing education that aren't run by Senior Disability Services Training Unit specifically may have a fee. That is my kind of start to that. Any thoughts on that from you, Cherry or Lynn?
Yeah, this is Cherry. In the context of the question or the discussion we had with performance measures, we're looking at the trainings that you already attest to that you provide to your staff. CPR first aid, orientation to SDS and the waiver process and PCS process, mandatory reporting, settings training if your service is subject to settings training, and CIR training. I think there's 6. And then depending on what services you offer, there might be some additional trainings, but it's really those core trainings that have no fee to my knowledge apart from CPR first aid. And again, most of them are SDS trainings that you can do train the trainer. So we're not asking you to go out and develop and implement any other trainings other than what the regulations require for this performance measure discussion. That's information you do offer and can offer in your quality improvement reports and in your training policy and procedure if you require additional trainings. But we're looking at measuring the ones by regulation that you are required to have you and your staff complete annually and have evidence in their personnel file.
Thank you, Cherry. Go ahead.
So this is Lynn. Therefore, I would say that no, the certification fee would not include any other types of training fees. It would be separate. That's a business expense for the entity.
Mm-hmm.
The other thing I would point out as far as the late fee goes, one of the things we're trying to get to is really, it's not for everyone, and most, a lot of providers actually submit things on time and they submit everything they need. But we do have those providers out there that submit such poor packets that we deny the application or deny the certification, and they just turn around and resubmit that again. So it's not that they're untimely, it's that they don't have maybe the business acumen or the frankly, the energy. They want us to help them walk them through that packet completely. And so they just resubmit it again. And we're again having to analyze and review those packets. It's very time intensive. So that's the part where the certification fee isn't just about tardiness. It's about if people paid even a nominal fee, they would take the time to complete a packet that actually meant something instead of just doing it again and again. So that's the only comment I would make on that late fee only.
Thank you, Lynn. A few of us have asked, are these fees in addition to the conduit fee to enroll?
Yes, they are. The SDS doesn't have any fees. And again, Conduit's not our contractor, that's healthcare services contractor, as we all know, I think. And enrollment's a separate process. Their fee is subject to their rules and federal requirements surrounding that. This is introducing a standalone SDS fee for certification.
Okay. So care coordinators are asking, would the fee be for an agency and a care coordinator? So both would pay or just one?
At minimum, agencies, we would offer feedback on individual, as folks know, we individually certify care coordinators. It's a much more streamlined certificate packet than it is a full agency's packet with operations manual and whatnot. So we would look for your feedback on any ideas about that, whether there should be or shouldn't be one for the individual care coordinator certification packet.
Number of comments about a quality improvement tool being helpful. There's thoughts out there in our list here about it would be great to have certain set examples of what quality improvement is. Folks are sometimes unclear as to do internal quality improvement. There's also a comment or a couple comments that are asking for templates for policies and procedures on our website. I can speak a little bit to that, and if you want to add to it. Policies and procedure templates, the philosophy or the intent behind having the provider do their own policy and procedure is so that it's relevant to their situation and their circumstances and their agency, because there's so many different formats, so many different ways the agencies are put together. We do have requirements that they follow, but the policy and procedure is going to be, the policy is a declaration of what you will do, and the procedure is how you will follow it. So those things are under the agency's world of responsibility, rather than offering templates. This is a system that works with providers to be a provider agency, rather than offering templated internal policies and procedure formats for providers. That being said, there's a lot of feedback about getting guidance on how to write policy and procedure, and I appreciate that feedback quite a bit. Anything to add?
Yes, Kara, thank you.
Oh, sorry.
Go ahead, Lynn. Okay, I was just going to add, I agree with what you're saying, Kara. That's been a request, a frequent request to have a template. And for the reasons you've just perfectly explained, we resist that because it really is a provider's business model and operations that they need to develop. Our application guidance that we offer online and is what we use to determine if the policy meets all the elements. We tell you what has to be in your policy and procedure per regulation, and you develop that. What we unfortunately get is shared policies. Sometimes we get packets with other people's business name on it. It's kind of a trend. And so our fear would be if there's a template, we would just get that back. The biggest challenge with policies and procedures is we get regurgitated regulations. And that's what we call the why. We know why you're operating that way because that's the regulation, but we're missing the how in many of these things. So that's where we spend the biggest body of work, is going back and forth, making sure all the elements are described about how your business operates under these regulatory requirements. But again, the template has been something we've resisted because of the fact of what we already see is providers are sharing policies, and we really need you to have your individual business plan for Medicaid developed for your agency. So when we come on site, we have something we can adjudicate your operations against, as that's expected to be implemented as it's given to us in the policy and procedure.
And this is Lynn. I would add to that. So we require policy and procedure because you're telling us how you're, like Cherry said, how you're going to run your business and how you're going to train your staff on all the regulations and rules that we have. It's really hard for us when I go on site and I find that nobody has been trained on that policy, or you're using a policy that a consultant gave to you or someone else gave to you, but your main leadership maybe has no idea what that really means. That's very problematic for us. And I can't then pass the red face test with CMS to say, yes, I fully believe this provider is complying with all the rules and understands and is training to these policies. And I'm not saying that's everyone, but I will tell you from a quality assurance standpoint and from a compliance standpoint, when we go out on site and find a policy and we recognize them being floated around or by certain people writing them, and if that's okay to hire a consultant to help you with a policy. But if you don't actually understand what that policy reads and says, and you're not training to it and you're not implementing it, that becomes very problematic for us to assure everyone that you understand what you're doing, or that your staff do, more importantly, that are doing all of the care. And so I just wanted to put that out there to caution everyone that that is something that we're very aware of and we see, and I understand the need for wanting to have training on policy and procedure. There's tons of it online about how to write a policy and how to put the how in there. So I would just offer that guidance, that that's really what we're looking for when we come out in a compliance or quality assurance review, that you are actually following what you said you were going to do.
Thank you, Lynn and Cherry. This is Kara again. There's a few of us are asking about national certifications and accreditations, looking for a little bit more information about what that is. Could you just give us a brief explanation about what national accreditation or certification is?
Sure. If you go back, maybe, Kara, to the slide, I believe it's slide 8.
Okay.
We sampled a handful. There's a couple we looked into in discussing maybe this idea. We have some agencies in Alaska that are CARF, the first one, certified or accredited. The term's accredited. I'm using certified because that's my language. So accreditation. I think we have some Council on Accreditation, COA providers. I would just encourage, if you're interested in this and this is all new to you, there's websites for these agencies. They're national and international accreditation firms to seek information off their website. Some of them specialize in certain areas of services, maybe more services for elderly versus developmental disabilities. You know, it just depends on what your service emphasis is in your agency, what might work for you. But these are a handful. There's 4 listed here that are the most common that we see, with maybe COA and CARF probably being the most common. The Council on Quality Leadership is a newer one too that we've become familiar with. So I would just encourage you to look on their websites and get familiar with it. And there are different processes. They can be very stringent, and that's why we're looking to try to leverage possibly a provider's increased efforts to operate under a national accreditation as a substitution possibly of the certification process. Lynn, would you add anything else to that?
No, I think, you know, it's simply just apples to apples. And that is, I think, the hardest bite of the apple for us. Just keep apples in my metaphors here. That's the part where I think we need providers. If you really are interested in pursuing this, we're going to need some, you know, great assistance from you. There are certain things that obviously the accreditation doesn't help us with. Like, you know, we have to assure that each of your employees are background checked and all of the people associated with your business. Obviously, that's not something an accreditation will give you. So there are certain parts that we would still have to do in certification to meet our legislative audit purposes and, you know, our federal requirements. But the accreditation itself is, you know, for anyone that's worked at an institution or had, you know, any of those, it's quite a lengthy process, and it's not often very cheap. I mean, sometimes it's expensive. And there are varying reasons depending on the agency of why you would want to become accredited, and that's really a business decision for all of you to make. So I would encourage you again to go to those websites. I think that's a really good idea.
Okay, thank you, Lynn and Cherry. There's a few suggestions here about, I just wanted to summarize them. A few have written in about requiring curriculum in the place of sort of along the lines of templates for policy and procedure. Could we possibly require curriculum for trainings that providers are required in reg that are outside of, you know, the ones that that you mentioned, Cherry, the core ones, for example, training for their direct service staff or assisted living training staff, assisted living home staff. Would we consider putting together curriculum requirements for that?
I think that's something we would have to talk about. I think in the past we had, and Kara, you would know more than I would, we did evaluate curriculum, I think, for maybe a SOM in the past. So it can get tricky. You know, the curriculum requirements, what must be trained to is rooted in regulation. So there's a fair amount that is already there that says that the training has to cover, which really should be the curriculum elements. But I'd be interested in hearing more about the idea.
And this is Kara. I'd be happy to provide resources as the training unit. I kind of hear more requests for resources here. So I think it's really good to get your feedback on that. So thank you.
And Kara, one thing I would add is that, you know, when we come out and do a compliance review or a QA review, or we, you know, as I'm building these performance measures for CMS, for reporting to CMS, one of the things that's really important is that each provider log and track the required trainings on each employee. So you have a training file for each employee, and that you have a way to assure that each employee is meeting that mark, whether it's at initial or it's ongoing or it's every 2 years, that you're actually tracking that. And that's something that we may ask for when we come on site. So I just wanted to throw out there that that's another thing that, you know, agencies, otherwise, how would you know if people have had the training? I think it's really important that you also track that.
Thank you, Lynn. Okay, a couple of thoughts here about if it's a training that is for a direct care provider, the agency does have to pay that provider to attend, and our reimbursement is for services provided to individuals. So it's a cost consideration under that. A couple of comments about that. I'm scrolling here. Could we develop? Go ahead. Yes, go ahead.
I was just going to say, I guess my only thought about that is these are trainings that should be already occurring, and this would be something that's already built into the business practice as it is. We're just looking for a way to measure it. So there shouldn't be a change. It should be already occurring.
A few have requested that SDS develop and internally manage training curriculums that are kind of like critical incident reporting and settings training, where there's no fee and it's a self-access training with a proof of knowledge, like a quiz or something like that. So a couple of requests for more of those. Okay, looking here. I see your questions about COVID-19 concerns and training, especially in-person training for CPR and first aid. The questions, I see them, I get them, and I'm happy that they're there, and they're important. They're just not part of this discussion. So I don't mean to ignore those. Our allowances are still in effect for CPR and first aid because there aren't any in-person classes available right now. There's a couple suggestions to allow more online trainings in the future when we didn't allow them before COVID, such as online CPR, first aid, online only. A couple of those thoughts. So I appreciate your thought process in putting it through the current situation with COVID-19 and asking for considerations after the pandemic has gone. So a couple questions about internal audits. Would certification staff walk an agency through what reports are needed? What guidance other than a quality improvement tool for a particular provider would be available to that provider? Thoughts on that?
So what we're considering is offering a quality improvement report template with examples of the data and information we would wish to see in the quality improvement report. The report contains many elements to include a provider's results of their self-assessment. In your quality improvement policy and procedure, you tell us already how you are assessing your operations. So we would be looking for that evidence in your report. So I'm not sure if the question is, what is your process? I would have to point you back to the policy and procedure that was developed for the quality improvement process. But the report is the evidence and the information in the report that we're considering offering a template for. As mentioned earlier, we get all kinds of responses to the item needed as a report for renewal. From very, very detailed, large agency, 300-page documents to a one-pager with a couple paragraphs. And we spend a lot of time. It's really important. That's probably the most important item for us to help evaluate your operations, and for you as an agency to evaluate your services, track data. It's important to track your data. And
So, oh, sorry, Jerry, I thought you were done.
Go ahead.
Oh, this is Lynn. I was just going to say one really quick example of that is medication errors. So you report that you've trained staff on medication administration and that you have a whole policy on that. And then you encounter medication errors within the course of the year. When you submit your quality improvement report to us, we want to know how you address those medication errors. It's as simple as, if it's the same staff that's made 2 errors, it didn't cause any health emergency, but that's a problem. You need to retrain that staff or tell us what you did with that staff. So what happens is, people submit things to us and it doesn't really tell us what you did with it, or you don't report on it at all. And we know it happened because we get the critical incident reports that you reported. So it's really important that you're looking at your own internal process for how you deal with the things we're asking you to deal with, and then you are honest and forthright in telling us how you dealt with it. I just wanted to sort of throw out that example of something. Those are the kinds of things we're really looking for. Sorry, Cherry, I didn't mean to interrupt you.
No, that's fine. I think that summarized the thoughts I had on the question.
Mm-hmm. Okay. So we have come up to our 10 o'clock mark here. We got mostly through our summarized thoughts here. I wanted to go ahead and thank Cherry and Lynn for this wonderful information. I want to go ahead and bring our session to a close and just remind us all that we have recorded your questions in text form, so you can continue to send them in until we actually turn off the session. So if you're still thinking about something, just finish your thoughts and put it in. This would not be the only chance that you'll have to share your thoughts. This is just sort of the beginning, and we'll be in touch with our provider community for further processes. Thank you very much for your valuable feedback and questions. And when you're ready, you can go ahead and click out. Go ahead, did you want to say?
I did, Kara. If you could just put the last slide up that has our email address. We do encourage you to enter your questions and feedback into the chat box, because we can print a report much more easily. But if you have other thoughts, you can email our certification mailbox that's listed here. And we're looking for feedback by Friday, July 31st, as we consider maybe next steps with what we've presented with you to you today. So you've got a couple weeks to think about it and give us some feedback on that. We look forward to hearing from you.
Mm-hmm. And we will have our recording available on our SDS Training YouTube channel. The link to it is on our website. I can share that by email. That's not a problem. We can also share our presentation by email with you. Also, no problem at all. And just give us some time to get that uploaded. It takes a little bit to upload to YouTube. So hoping by the end of today that we'll make something available, if my computer's happy with me today or my internet is. Okay, so thanks again, Cherry and Lynn, and we look forward to continuing the conversation with you. And we'll connect with you in future weeks about this topic. So thanks everybody, and I hope you have a wonderful day. And go ahead and click out when you're ready. I'll leave this open for about another minute or so you can finish your thoughts, and then I'll close down the session. Okay.
Thank you, Kara. Thanks for running it.
Absolutely.
Bye-bye.
My pleasure.
Thank
Bye-bye.
you. Bye-bye.